Dr. Vold, at the Glaucoma 360 meeting, you discussed the new horizons in glaucoma devices. Could you give a summary of your presentation?
Sure. As you know, micro-invasive glaucoma surgery is really taking the world by storm here, especially in the glaucoma community. In the past, when we thought about surgery, we really reserved that mainly for people with more end-stage or advanced disease. And so we would start with medications, maybe throw in some laser in there, and then as a last resort, we would do interventional surgery such as trabeculectomy or tube shunts. Well, now we've got all these new procedures. We have the eye stent, we have the cohook dual blade, we have the trabectome, we have the ab-internal canaloplasty, we have the Visco 360, Trab 360. It's really kind of amazing, all the different procedures, and including now the approvals of the SiPass, which is the first supraciliary stent, and then we have the Zen implant, which is a subconjunctival implant. And so it's really changing everything about how we approach glaucoma. Not to mention we have newer drugs coming down the line, as well as newer drug delivery systems. And so really what I think we're finding is that because of compliance issues, and also we're finding that these newer procedures are much safer, and they also are efficacious, we're intervening earlier with disease. So some of the things that I've kind of taken home in my lecture is really a couple things. Number one, in early disease, you really need to strongly think about doing a trabecular bypass procedure. We know that the longer you've had the disease and the longer you're on medicines, the worse these procedures work because there's scarring of the collector system. So we want to intervene earlier there. And then also in mild to moderate glaucoma, we're also finding that supraciliary stents really are excellent at increasing uveoscleral outflow. They have incredibly good safety profiles. But also, it also is very efficacious in lowering pressure, so people that are on 2 and 3 glaucoma medications, a lot of times we can get them off all of their medications. And now with the approval of the Zen implant, wow, we have a procedure that can really get low intraocular pressures, and so certainly advanced disease, but really I suspect potentially in a combined procedure with cataract surgery and also moderate disease, we may have a procedure that can really lower intraocular pressure, keep people off their medications, and really enhance quality of life. The last point I would like to just kind of take home for you is the fact that I really think cataract surgery is a great way to lower intraocular pressure. We know that especially in patients with angle closure or pupillary block, it really lowers pressure. And so when we add this potentially with the MIGS procedure, we can really a lot of times not only improve their glaucoma control, but also their quality of vision. And I think sometimes in the past with trabeculectomies, we get the pressure lower, but the patients wouldn't see better. Their cataracts would grow. A lot of times we would give them a couple or 2-3 diopters of astigmatism because of their filtration bleb. And now I've got procedures where, gosh, not only am I lowering their intraocular pressure, but I'm going to treat their astigmatism with an intraocular lens, such as a toric lens. And the other thing I also say with the advances of intraocular lenses, things that we never would have thought possible, like extended range vision lenses, I really think those are going to be things we're going to want to offer our glaucoma patients moving forward. So in a nutshell, we're changing glaucoma by intervening earlier with more incisional type procedures. And I think drug delivery also is going to be something that we're jumping in much earlier in disease as we move forward.
Do you see drug devices, not drug devices, do you see devices in general being the first line of defense? Is that ever going to be a possibility?
You know, I think it very well can be, and especially the cost of medications is very high for many of our patients. Compliance is really pretty awful. We've got studies that show that even with a single once-a-day prostaglandin, you know, maybe 50 to 60% of these patients are actually fulfilling their prescriptions over the course of 1 year, and that's just not going to get the job done. I will tell you, a selective laser trabeculoplasty or micropulse laser trabeculoplasty is also another thing I really think we need to think of as a first-line therapy. And then the other thing I'll tell you is these procedures right now, a lot of times we're doing them in the operating room. My guess is that the day is coming very quickly where we're going to actually start to offer these in the clinic, and I think that will change things dramatically as well.
Do you see devices in general, how do you see the evolution of that? I mean, it's evolved a lot since the first eye stent. I mean, it was a basic drainage device, and now we've got all these other variations of it. How do you see the technology evolving?
You know, I think one of the things that we really are doing right now, we're kind of throwing darts, but we don't know exactly what the target is so much. And I think as we get more imaging techniques of the collector system, Schlemm's canal, we're going to be able to tailor our procedure based upon the anatomy of the eyes. If we can do that in the office or potentially at the time of surgery, I think that's going to change things dramatically. Another thing I think we just have to think about also is, for instance, now with cyclophotocoagulation, with these micropulse lasers, we really believe we're probably increasing uveoscleral outflow as opposed to just destroying the structure of the eyes and reducing the amount of aqueous that is being produced. And so it changes things dramatically. And so I think it's kind of like any technology, it evolves over time. I still think we're in the infancy. We're certainly making great progress, but as we get smarter, we're going to be able to target our therapy really to the disease process, which may be slightly different in each patient. So it's really custom glaucoma therapy.
Thank you, Dr. Vold. Appreciate your time.